Hello, I'm Jen Letchford, Tissue Viability Nurse Advisor with Coloplast, and I'm here today to talk to you about wound preparation and removing those barriers to healing. Our learning objectives for today are to have a bit of an understanding of the current climate and impact that wounds are having, to understand the difference in terminology between debridement and wound preparation, to gain a little bit of knowledge around wound preparation methods, and to understand the impact of wound preparation on healing. We should be able to discuss which wounds require preparation and how best we can do that, as well as thinking about a real simplified approach to managing our wounds. So I'd like to introduce you here to the Coloplast three-step approach. The first step is assessment, and a thorough assessment of a wound is absolutely paramount to set out our wound objectives and help this patient towards healing. Step 2 is to prepare a wound, and preparation really means to remove any barriers to healing. Then we move on to step 3, and that treatment of a wound. And here we can look at the types of products that we might select in order to create those optimum healing environments. So we're all very aware that the demographic of patient is changing, our workload is increasing, workforce possibly reducing, and certainly funding to services has been reducing, which is having a huge impact on the way we manage wounds and how we manage wounds. We're also seeing that the patient setting in which we manage wounds is changing slightly, and we're seeing more patients within community and primary care settings. So the impact of chronic wounds. 3.8 million wounds are managed every year by the NHS, and that's at a cost of around £8.3 billion. 6% of that £8.3 billion can be due to the actual cost of treatment, cost of wound care products. Resources that we look at when we're treating wounds and the place and the setting in which we're treating them. You can see here that district nursing, community nursing, practice nursing and healthcare assistant time has all increased in the last few years. So we are definitely managing more wounds in these settings and with these types of clinicians. And here I'd just like to introduce you to Betty's story and a suboptimal versus optimal pathway of care. Now, if we look to start with at the suboptimal pathway of care, at 70 years old, Betty was identified as being slightly overweight at a health check. At 74, she grazed her ankle and put a plaster on. After 5 weeks, it hadn't healed, so she went to see her GP and she was given antibiotics. A further 2 weeks down the line and still the wound hadn't healed, so she went to see a practice nurse. 6 weeks of treatment with the practice nurse and increased visits to 3 times a week at this point. Another antimicrobial was tried, again not successfully, and she actually then had a referral to the vascular services. 8 weeks later, she was seen by the vascular team and continued with treatment for a further 5 weeks. By this point, Betty's wound had deteriorated so much that she was then being needed to be seen by community nurses and district nurses. She did go into compression but couldn't tolerate the compression, and Betty ended up with a cellulitis and an admission to hospital, where she stayed for 5 days for IV antibiotics. So after various treatments and compression hosiery, Betty did eventually heal after 2 years. And that was a total cost of £5,673. If we now compare that to an optimal pathway of care, at 70 years old, when Betty had that health check, she would have been given compression hosiery, so that when she then had the graze to her ankle at 74, she visited the pharmacist. And as per their lower leg pathway, she was seen promptly by the practice nurse just 2 days later. She had that full assessment and ABPI. After 5 weeks of treatment, the ulcer had healed, and Betty continued to wear her compression hosiery with an annual lower limb assessment. And she'd healed completely within 6 weeks at a total cost of £505. So not only did that optimal pathway of care really help Betty's healing trajectory and healing outcomes, but it also meant that the nurses weren't needing to spend as much time dressing her wound, and the cost implication as well was less. Clinicians, all of us as clinicians, face challenges, and some of the challenges that you might see in wound healing are this excess slough in a wound bed, necrotic or tissue and bacterial load presence, or hyperkeratosis and hyperkeratotic skin, all of which can have real challenges with wound management and wound healing. Some common things that you might hear from clinicians, or that certainly I've heard, is I don't want to disturb the wound bed or the process of healing because of cleansing. I try not to clean as it drops the wound temperature. I was always taught only to cleanse the wound edge, never to touch the wound bed itself or the peri-wound skin. Or I don't want to cause trauma by disturbing the wound. Well, actually, we do need to be preparing wounds. We need to be removing any of those barriers to healing, and we need to be removing any devitalised tissues in order to create that optimum healing environment. So why is effective wound preparation so important for us? Well, the wound cleansing should be seen as an integral part of our wound preparation and wound management. We really want to try and optimise that wound environment by removing any debris or reducing the bacterial load and prevent that biofilm activity. We know from research that slough, non-viable tissue and biofilms can all increase the risk of infection, but also slow that healing process, keeping that wound in its inflammatory phase of healing. So we see increasing risk of infection. Slough and devitalised tissue will also inhibit that healthy tissue formation, and they can limit wound assessment, which leads to delayed wound healing. And delayed wound healing then has an impact on the patient's quality of life. It means that there's an increased time burden of wound treatment and an increased cost in treatment as well. So why should we remove devitalised tissue from a wound bed, wound edge and peri-wound skin? The devitalised tissue leads to increased healing time. It increases the risk of infection and bacterial load and biofilm presence, and it prolongs that inflammatory response from the body. So it will not only have an impact on our patient and their quality of life, but that drives up the treatment costs and the time spent by clinicians. So how can preparation support your wound healing? Well, it removes those risks of infection by removing the physical barriers such as slough, devitalised or necrotic tissue. We can improve healing outcomes by creating that optimum healing environment. That can also mean improved pain levels for a patient, as maceration can be because of these devitalised tissues starting to break down and increasing exudate levels because of that. So actually by removing the devitalised tissues, we can help with pain associated with maceration potentially. And an improved quality of life for the patient because it will mean less time spent with the wound. It's clinically proven that cleansing and debridement speeds up the wound healing process. And you can see here from the graph on the slide that debridement once every 2 weeks led to an average wound healing time 76 days versus debridement once every week, which meant average healing time of 21 days. So quite a significant difference, and that shows the impact that really thorough wound preparation can have. So we want to remove the barriers to healing, and we do that through cleansing and debridement, and that can remove those physical barriers such as slough, non-viable tissue and biofilms. So what do we mean by the term debridement? Debridement is defined as the removal of dead and devitalised or non-viable tissue, removal of infected or foreign bodies within a wound bed or edge. When we talk about wound preparation, we're talking about a holistic approach and a systematic approach to removing those barriers to healing. So why is wound preparation so important? Dead and devitalised tissues create a physical barrier preventing epithelial cells from migrating across a wound, which slows down that healing process. Those dead and devitalised tissues, or biofilms, might prevent a topical antimicrobial or agent from working, and they can also really hinder our wound assessment. Those dead and devitalised tissues that we might think of, for example, in a pressure ulcer, could mean that we can't see the true depth of a wound, in which case, can we thoroughly assess it? Or do we need to prepare that wound, remove those devitalised tissues before we can undertake a really thorough assessment? Treatment time and costs also increase when preparation is not completed. So the benefits of wound preparation for the patient. Patients can really benefit because actually we've already seen that with good wound preparation, healing times improve. It also will help to reduce any malodour or associated exudate increase by removing those devitalised tissues. It reduces that risk of infection for our patients and improves those healing outcomes and healing times. So it has a limited impact on those patients' quality of life and activities of daily living. There are different types of debridement that we can look at here, and we'll go into each of these in more detail, starting with autolytic debridement. So what is it? Autolytic debridement is the process by which the body attempts to shed that devitalised tissue, and it does that through the use of moisture. Our dressing choice will also support autolytic debridement. Biological debridement. What I mean here is actually the use of maggots in a sterile environment, which will help to break down those dead and devitalised tissues. Then we move on to enzymatic debridement. And what, again, do I mean by that? Well, this is actually normally a topical agent or a chemical that helps to liquefy that necrotic tissue through the use of enzymes. Then we move on to mechanical debridement, and this is something that maybe we see more frequently in practice and certainly more accessible to a lot of people. Traditional methods of this would be using the wet to dry gauze, but we know that that can also have issue and cause trauma to a wound bed on removal. Other forms of mechanical debridement would be debridement tools, manual debridement tools that we can use and access in our own practice. It could be hydrosurgery, so water pressures that are also used to help with this mechanical debridement. But there are many products on the market and there are many tools available, and it's accessible to everybody and doesn't have or require an extra competency to undertake mechanical debridement. Then we have conservative sharp debridement. This does require extra training and specialist input quite often. So this again would be that removal of those dead and devitalised tissues, but you would do that using a scalpel, scissors, forceps or sharp object. This can be done in theatres and quite often your tissue viability nurses would be able to support you with this if you felt it was appropriate for your patient. It's worth referring and getting that second opinion. So which wounds should we prepare? Well, actually, all wounds need a degree of wound preparation, and that could be cleansing. It could be cleansing and debriding, or it could be that we're trying to avoid causing any further breakdown of tissue. So our assessment is key. How often should we be preparing the wound? Well, actually, this should be based on your clinical judgment and your assessment, looking at your treatment goals and objectives and looking at the patient's pain levels. When we're talking about assessment, we need to think of the patient holistically. We need to identify any underlying diseases, as that may impact on whether we feel a patient is suitable for debridement of a wound. We also need to look at nutritional status, mobility, any other medications that the patient is taking, allergies, sensitivities, and the wound characteristics themselves. Wound preparation can really help us to assess, and actually removal of those non-viable tissues and debris and bioburden within a wound can really help to facilitate an optimum healing environment, but also enables a really clear, accurate wound assessment. And clear assessment helps us to form a treatment objective and plan to help manage that patient and help them with optimal healing environments. So, overcoming the physical barriers to healing. And here we need to look at the wound bed, the wound edge, and the peri-wound skin. We need to think about some of the challenges that we identify in the wound assessment, and we need to highlight key areas of concern. It could be that we're seeing that there's devitalised tissue in a wound bed and on a wound edge, but that the peri-wound skin is okay. Or it could be that we're seeing hyperkeratotic skin to the peri-wound, which is also having an impact on healing. So it's important that we look at all of these areas of the wound, not just focus on the wound bed itself. When should we be cautious when it comes to wound preparation? Actually, we need to think here about if a patient has a lower limb wound, are they diabetic, and are they suitable for debridement or wound preparation? And it may be that you are needing specialist advice with this, so a referral will probably be suitable. If a patient has a known arterial flow problem, then again, this will mean lack of blood flow, which means delayed healing, and you may not want to disturb that wound and prepare or remove any tissues from that wound until you've established what your blood supply actually is. So again, these types of wounds might require further assessment by a specialist service. And if the healing ability of somebody is impaired because of medications or an underlying health concern, then it's important to take a multidisciplinary team approach in managing those wounds. When we think about biofilms and wound preparation, actually the most important thing to do is to remove that biofilm, and that can be done manually. Biofilms will delay wound healing. They increase the level of exudate and slough. They can also increase that inflammatory response, malodour, and give a higher, they have a higher bacterial load. Therefore, the patient's more at risk of developing an infection. In order to manage biofilms, it's important that we do remove as much of the biofilm as possible or disrupt that biofilm before we add our treatment. Without disrupting that biofilm, you're not going to get the best out of the selected treatment, so an antimicrobial, for example, because it's not going to be able to penetrate through that biofilm. So manual removal or preparation of this is really key. The international best practice management statement for biofilms is to prepare our wound through cleansing and debridement. Then to apply a barrier dressing and treat any bacterial load or infection. So to manually debride and then select an appropriate treatment for our patient. Frequency of preparation and management of biofilms. Actually, what we know is that it's really important to remove biofilms at every dressing change. So we want to be able to get on top of that biofilm by manually disrupting before selecting our treatment and applying our treatment or our antimicrobial. So our learning objectives were to understand the current wound care climate, to understand the differences in terminology between debridement and wound preparation, to think about why we need to prepare wounds and what that would mean for a patient if we didn't prepare a wound, and the impact that preparation has on healing. Hopefully today's session has enabled you to think about these things in more detail, and I'd like to thank you again for joining me today.